My name is Jana Adams and I'm working together with Renee Fisher to review the skeletal, articular and muscular systems in association with the drop punt kick. The skeletal, articular and muscular systems play an essential role in the studies of human movement and is also referred to as the study of osteology for the study of the skeletal system, arthrology for the study of the joint system, and myology for the study of the muscular system. This field of inquiry involves systematically understanding how and why people move and the factors that limit and enhance our capacity to move. The skeletal system consists of the bones of the skeleton, the cartilage, connective tissue, and ligaments which provide stability or attach to bones. The key functions of the skeletal system involve support, storage of minerals and lipids, protection, and production of blood cells. The study of osteology involves analyzing the skeletal articular system comprising of connective tissues that serve primarily mechanical roles in locomotion and protection of vital organs. Bones provide support with movement through joints acting as pivot and lever points for muscle-driven motions in tendons, ligaments, and menisci as the joints blend the forces produced by the muscles into controlled, stable skeletal motions. This system can be classified into divisions of the structural classifications of fibrous joints, synarthrosis, which are immovable, a cartilaginous joint, amphiarthrosis, which are slightly movable, and synovial joint diarthrosis, which is freely movable. The study of arthrology involves the synovial joint, which is classed in three categories, including geometric form, gross movements, and joint structure, and its complex articulating surfaces, discs, or meniscus, such as simple, complex, and compound joints. Joint classifications also include pivot, hinge, condyloid, saddle, plane, and ball and socket joints, which are determined by the direction of muscle fibers through sarcomeres determined by the transverse plane involving the superior and inferior portions of the body, the sagittal plane separating the body into left and right portions, and the frontal or coronal plane separating the body into anterior and posterior portions. The synovial joint comprises of articular cartilage consisting of smooth, white tissue for a smooth bearing surface, a joint capsule utilized for joint movement boundaries for stability and resistance, the synovial membrane for the synovial fluid within the joint cavity and debris removal from wear and tear, the synovial fluid for friction lubrication, protection, and nutritional cell delivery, and the ligaments which cross joints for joint integrity, movement, and resistance from tensile forces. The musculoskeletal system includes muscles, bones, ligaments, tendons, and soft tissue to support the body's weight and movement and are divided into axial and appendicular muscles. The muscle tendon units involve bone, tendon, muscle, tendon, bone in relation to joints. In relation to the deconstruction of a sporting technique, this involves the drop punt kick, which is the standard kicking technique in most situations due to a combination of accuracy, distance, and speed of execution. This is broken down into the wind-up, action, and follow-through phases. The wind-up phase purpose involves speed, momentum, balance, and velocity. This begins with the flexion of the knee, synovial joint, and the sagittal plane with the articulation of the proximal leg involving the thigh bone, the femur, shin bone, the tibia, and kneecap patella, utilizing the tibiofemoral and patellofemoral joints. Whilst in the frontal posterior plane, the engagement of the musculoskeletal system involving the quadriceps, hip flexor muscles, also known as iliopsoas, knee extensor muscles, and the rectus femoris is responsible for the production of velocity for preparation for the action phase. The flexion of the pelvic girdle in the trunk region, the hip, ball and socket, cartilaginous joint, in the frontal posterior plane involves the cervical, thoracic, lumbar, sacral, and coccygeal region, which adapts for body balance. The plantar flexion in the ankle hinge joint involves the articulation of the talus, tibia, and fibula bones with the anterior talofibular ligament and soleus, gastrocnemius, and plantaris muscle to produce plantar flexion at the ankle joint. The ball drop phase for guiding the ball with a cradling hand involves the flexion of the shoulder in the sagittal plane of the ball and socket synovial joint with the articulation of the humeral head with the glenoid cavity or fossa of the scapula. as well as the musculoskeletal system involving the pectoralis minor being on the medial aspect of the coracoid, where the coracobrachialis is attached to the tip of the process on the medial side, and the short head of the biceps being attached to the tip of the process on the lateral side. From the shoulder flexion, further flexion occurs at the hinge synovial elbow joint with the articulation of the humerus, ulnar, and radius, with the engagement of the ulnar and radial collateral ligament and the annular ligament for elbow support. The sagittal plane opposition movement with the hand and ball interactions involve the articulations of the carpals, metacarpals, and phalanges, involving when the ball is being handled, the fingers will abduct once the ball has been dropped and is ready for the action phase. The action phase involves the swing of the foot and ball to action. This involves the extension of the knee hinge synovial joint in the sagittal plane with the articulation in the proximal leg involving the compression of the femur, tibia, and patella from ground reactive force utilizing the posterior cruciate ligament, also known as PCL, for stability. Whilst in the anterior plane, the proximal leg has the engagement of the superficial quadriceps, hip flexor muscles, also known as iliopsoas, and rectus femoris, as well as the hip abductors, adductor magnus, adductor longus, adductor brevis, pectineus, and gracilis for strength and kicking. The ankle hinge synovial joint involving the articulation of the talus, tibia, and fibula bones with the malleus ligament for dorsiflexion from the tibialis anterior, extensor hallucis longus, and extensor digitorum longus, as well as the musculoskeletal system involving the gastrocnemius, soleus, and plantaris muscles for effective velocity force. The follow-through is the final phase, which involves the full extension of the knee through the posterior cruciate ligament, the extension of the pelvic girdle for stability, and the ankle joint transition from plantar flexion to dorsiflexion for effective velocity in the drop punt kick motion. So what injury is involved in the drop punt kick? The adductor strain or groin strain is one of the more common injuries that are caused by the drop punt kick. The adductor muscles originate at the pelvis and insert themselves into the inner aspect of the femur. When performing a drop punt kick, the adductor muscles are stretched and can be overstretched, causing significant swelling and pain. The muscle becomes forcibly stretched while being concentrically contracted, with the greatest eccentric tension placed on the adductor complex when the leg is rotated and abducted. The result of this is the adductor muscles contracting to generate force, but through eccentric and concentric opposing forces. In the case of groin strain, the dominant leg is the most injured and has the highest likelihood to sustain significant injury. What type of injury is the adductor or groin strain? Groin strain can be both acute and chronic and depends on the extent of the damage which is caused. Acute pain is defined as onsetting quickly and dissipating quickly, whereas chronic pain is determined to last for more than 6 months and continues even after the injury has been treated. While some groin pain can be relieved and treated with rest and minor first aid, some groin strains become chronic due to inadequate rehabilitation and care at onset. Groin strain can also become chronic if the injury to the groin is substantial enough. The injury would become chronic immediately as the likelihood of recovery time is drastically increased. So how does the adductor or groin strain injury typically occur in a drop punt kick? Groin strain commonly occurs when the muscle is being forcibly stretched while being concentrically contracted. The tension is placed within the adductor complex where the leg is externally rotating and abducting. This occurs between opposing forces involving the swing through with the kick being met with the ball, where the athlete rotates and adductor strain is caused. The dominant leg is more commonly injured and can sustain significant injury. For example, when an AFL player is performing a drop punt kick, their leg is in adduction to meet the significant resistive abduction force from another player, which puts huge amount of load on the adductor complex, leading to injury. The anatomical structures involved in this injury could be in relation to any of the adductor muscles. These muscles are the adductor magnus, which originates at the inferior pubic ramus and ischial tuberosity and inserts into the linea aspera and adductor tubercle. The adductor brevis originates at the inferior pubic ramus and inserts into the linea aspera and pectineal line, and the adductor longus originates at the anterior pubic ramus and inserts into the linea aspera. While these muscles are the primary adductor complex, these are associated by 3 additional muscles with abduction. These are the gracilis, which aids in rotation internally in hip flexion. It originates at the pubis symphysis and pubic arch and inserts into the proximal medial tibia and pes azerine. Pectineus muscle, which originates at the pectineal line of the pubis and inserts into the pectineal line of the femur. Lastly, the obturator externus. This muscle originates at the obturator foramen and inserts into the posterior aspect of the great torsional. How is the injury usually diagnosed? Imaging studies are the initial evaluative choice of suspected adductor strain, with anteposterior views of the pelvis and frog-like views of the affected hip are recommended. These images can also be used to diagnose other forms of groin pain such as osteitis pubis, avulsion fractures, and pelvic or hip stress fractures. In some cases, MRIs are recommended to see if there is a muscle edema or hemorrhage at the site of the injury. Bony injuries are better indicated on an MRI as they illustrate the extent of the damage more clearly. Ultrasounds further the visualization of the tendon and bony attachment sites, which can be utilized to evaluate the extent of the injury, which is then able to give an approximation of recovery time. How common is the injury? Groin strain is the 3rd most common injury and case of games missed in the AFL. This is remaining low with an average of 2.2 new cases of groin strain, causing 7.1 games missed per term. Groin strain occur in a variety of other sports and is a primary injury among athletes. European soccer players' adductor muscles are the 2nd most commonly injured muscle group at 23%, just behind hamstrings at 37%. Another study with soccer players shows that adductor strain represents anywhere from 9% to 18% of all injuries, and sub-elite male soccer players account for 51% of injuries. How is the injury usually treated? Adductor groin strains are managed in a more conservative fashion with the use of rest, ice, compression, pain relief, and physical therapy. The rehabilitation should include stretching the range of motion and the strengthening of the affected leg with the aim of a gradual return to sport. Acute injuries may return as quickly as 4 to 8 weeks compared to chronic strains, which can take months to achieve the desired results. Other treatment options include osteroid injection into the adductor muscles combined with the use of ultrasound, and even more severe cases, surgery may be required. Surgery may only be required due to poor recovery with conservative management. Groin strains are separated into 3 grade levels. Grade 1 groin strains occur when the muscle is simply overstretched and damages less than 5% of the muscle fibers. Walking without pain is possible, but more strenuous activity may cause pain. Grade 2 is a tear that causes damage to a significant percentage and causes pain even when walking or performing light exercise. Grade 3 groin pain is a tear that goes through the majority of the muscles and at times can go all the way through. This is a sudden and severe pain. How can the injury be prevented? As groin strain can be both painful and place athletes out of playing or competing for months, prevention is the best possible outcome for groin strain. To do so, the best method of prevention is to always warm up your legs and groin muscles before any type of physical activity. This can be achieved by any light physical activity that increases body temperature. Increasing the body temperature helps dilate blood vessels and helps blood flow, ensuring the muscles are at their optimum level for usage. Strengthening exercises also help prevent groin strain as it allows for the muscle to essentially become stronger and decrease the likelihood of a strain. Lastly, If a pain of tightness is felt within the groin or inside of the thigh, stop exercising or competing at once. In conclusion, the drop punt kick functional anatomy incorporates a range of different aspects from the muscular, skeletal, and articular systems, and when done incorrectly, can cause some serious injury that can have lifetime effects. Thank you for listening.